The following episode is brought to you by the American Urological Association. This episode is part of a special series highlighting the AUA Update Series, Volume 45. In this episode, we will be covering some of the key lesson points with Dr. Rohit Reddy, one of the authors of Lesson 2, Perioperative Management of Urinary Diversion, what every urologist should know. Now in its 45th installment, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to subscribe to the AUA Update Series, please visit the AUA University.
Welcome to another episode of the AUA University podcast. I'm Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today we're diving into Lesson 2 of the AUA Update Series, Perioperative Management of Urinary Diversion, what every urologist should know. This is a topic that touches all of us in practice, whether you're the surgeon performing the diversion, the hospitalist co-managing the patient postoperatively, or the urologist following up after discharge. Understanding the range of complications and how to navigate them is essential. It's my pleasure to introduce today's guest and author of this lesson, Dr. Rohit Reddy. Dr. Reddy is a urologist at the Kelsey-Seybold Clinic in Houston, Texas, whose practice focuses on urologic oncology and robotic surgery. He completed his urology residency at Temple University and fellowship training in minimally invasive robotic surgery at Houston Methodist. Rohit, welcome to the podcast.
Thanks for having me. I'm really happy to be here.
So before we get into clinical content, I'd love for you to help our listeners understand how to get the most out of this AUA update. When you think about someone sitting down with this material, a resident, a fellow, or a practicing urologist, how would you suggest they approach it?
Yes, so I think the goal of this lesson was really to create a practical guide to the perioperative management for any urinary diversion. And so we start on this lesson by touching on the different types of diversion at a higher level. But I would think the real focus of this lesson is really how to optimize patients before surgery, what technical and perioperative factors matter, during the surgery, and then also, after, how to recognize and manage common postoperative complications.
These are great points. I think the organizational framework matters as much as the individual facts. And that brings us naturally to understanding complications associated with urinary diversion. There's a table in the lesson that I think is worth highlighting. So we're going to spend some time on that. I think it focuses on early and late postoperative complications after urinary diversion. Can you walk us through why that table is such a valuable resource and what stands out to you clinically?
Yes, definitely. So I think the table that we included in this lesson is kind of the backbone and the highlight of this lesson in terms of providing a framework for dealing with complications after a urinary diversion. So the biggest takeaway, I think, is that the complications after a urinary diversion become a lot easier to approach when you think about them in a structured way, especially by the timing of when the complication happens and also the clinical presentation. So, early complications, which can happen within the first 30 days, tend to include things like ileus, urine leaks, abscesses, bowel issues, infectious complications, whereas later complications, so after 30 days, that could include strictures, stomal problems, hernias, or any metabolic issues. So I think the value of this table is that it helps the reader move from just recognizing, something's wrong with this patient to more, what are the likely problems based on when this patient is presenting and how exactly they're presenting.
I think these are great points. That table is almost like a cheat sheet, right? For anyone managing these patients. I think what's important for those listening to understand, as you mentioned, is the timing of a symptom, right? Or finding that will potentially direct your differential and workup. So I'd encourage listeners to bookmark that table in the lesson. It's really the kind of reference you can come back to. There's certainly a level of detail in that table that we simply can't capture in the short podcast conversation. So I'm not sure if you have any other thoughts on how that table puts the whole framework of the lesson in place.
Yeah, I think really, yeah, obviously, within that table, there's a lot of information about, what exactly could potentially happen after urinary diversion in terms of complications. But I really think that what we should really be getting from this table is the framework to be able to narrow the differential based on the timing, and then think more systematically based on the exact type of complication that's occurring.
Great. Now let's talk about the clinical cases in the lesson. I think the case-based format is probably one of the most effective tools for learning perioperative management. And this update includes 4 cases with accompanying images. Can you give us a quick orientation to each one?
Yes, definitely. So there were 4 cases that we included in this lesson. They were all based on different scenarios that happened during my training and fellowship at Houston Methodist, and I think they all kind of highlight different scenarios that could happen after a urinary diversion, and how exactly to decide on the systematic management, the diagnosis, and the actual way that we can treat these complications. So the first case that we discuss is a fever and a postoperative fluid collection, which is a very common complication after a urinary diversion. I think the biggest teaching point from that case that we discuss is that not every postoperative fluid collection is the same, and the first step is really figuring out what type of collection that you're dealing with. Not to get too much into the details of it, but the differential could include different types of urine leaks, bowel leaks, abscesses, lymphoceles, either hematoma or seroma. And so what really matters is putting together the clinical picture of the patient, the imaging findings, and then determining whether or not you need to drain the collection, and then looking at different lab values within that collection to help identify the true source of the leak, or the collection in general.
And I think for that case, the lesson, I think, really does a nice job of walking you through the workup and decision making around that management.
Exactly. Yes. And so the second case, it deals with a patient that has hydronephrosis and possible obstruction. So the key point there is that hydronephrosis in general after a diversion is really just a finding, but not a true diagnosis. So there's definitely possible causes of the hydronephrosis, including strictures, malignant obstruction, stomal obstruction, or even reflux. And the workup for that is really dependent on the overall clinical picture and what the imaging is showing. So I think one of the important pearls is that not every patient with hydronephrosis needs immediate intervention. If they're asymptomatic or if their renal function is stable, there may be situations where observation is reasonable and often the best course of management. But once you start to see things that may complicate it even further, like infection, worsening renal function, low urine output, or signs of sepsis, then in those scenarios, decompression becomes much more urgent. So I think the main lesson there with this case is to be thoughtful and systematic about both the diagnosis and then the timing of intervention for these patients.
Yeah, what I find nice about it is the image really helps illustrate the level and degree of obstruction, and you cover different ways for managing this situation, both from an endoscopic standpoint and potential surgical management.
Definitely. And so the third case that we talk about in this lesson is a patient that has an ileus. And I think the biggest takeaway with this case is that any postoperative ileus is common, but you don't want to be too comfortable with just saying it's an ileus and not really exploring it further. And most ileuses can be managed conservatively initially with bowel rest, decompression, fluid and electrolyte management, and in general just time. But the key is recognizing when the patient is not following the expected course. So if they're becoming more distended, if more tachycardic, white counts going up, or if imaging suggests a transition point or another actual mechanical issue, then it's important that in those scenarios, something maybe more significant, which might require more intervention.
Yeah, great. And again, this particular case, obviously, sticking with the theme of the others, really highlights management strategies, including enhanced recovery protocols that are in particularly helpful for this type of problem.
Exactly. Yeah. The ERAS, or the enhanced recovery protocols that we've been using for any type of urinary diversion and the postoperative management, I think has really helped to speed up the recovery process and get them out of the hospital quicker. And so the last case that we talk about is a patient that has leakage around their stoma. So, the case with this, patient is really about localizing the leak, where exactly along the urinary tract leak is happening from and deciding how to manage it. So, leakage around a stoma could be a more distal stomal issue above the fascia, like a dehiscence, or it could be more proximal, either within the stoma or even at the uteroenteric anastomosis. And, there's different ways to manage it based on the location. So the workup, I believe involves a combination of the exam, imaging, and often endoscopic evaluation, depending on what you're seeing, in the scenario. So one of the helpful pearls from this scenario is that not every leak needs a major operation. Some can be managed effectively with urinary diversion, catheter drainage, wound care, and optimization of nutrition or tissue healing. And so really the message is to figure out first where exactly the leak is coming from, and then whether or not you need to be conservative with your management or more invasive.
Yeah, I think that last point for those in our audience in particular, knowing when to recognize the leak early, as you mentioned, understanding imaging findings, and knowing when conservative management is appropriate versus when surgical reintervention is needed, that's all covered in detail in the update with a supporting figure. So, Rohit, these cases are the kind of scenarios I think that every urologist in training or in practice will encounter. And I want to emphasize to our listeners that the images in the lesson are really essential to fully appreciate these cases. And you can see them in lesson 2 of this particular update series and work through figures 1 through 4 in their full context. As we approach the next phase of this conversation, I'd love to hear your thoughts about, for our listeners, basically with the 2 or 3 takeaways that you would like to leave folks from this particular update series.
Absolutely. So, I'd probably leave the listeners of this podcast and the readers of the lesson with 3 big takeaways. Is that first, patient selection and preoperative optimization matter a lot, especially for things like renal function, nutrition, patient frailty, and choosing the right diversion for the right patient. Second, a lot of postoperative issues become much more manageable if you approach them in a much more systematic way. And so I think with the table that we provide in this lesson, and then also the 4 cases that we discuss, they really go into the timing of the presentation, the anatomy of what exactly is going on, and then the complication patterns and how to deal with them. And third, I think the big, one of the biggest takeaways is really that patients often do best when you involve a multidisciplinary team. So, and getting them involved early. So whether that's IR, nutrition services, general surgery, or any other services, depending on the exact type of complication, I think is really helpful for providing the best care for these patients. So I think, urinary diversion is, can be very complex, but if you approach these patients methodically, a lot of these complications become much more approachable.
Very well said. And I think, proactive preparation, early recognition of things that can happen after surgery, and certainly appropriate management, I think are good things to keep in mind. Dr. Reddy, thank you for taking the time to join us today and for the incredible work that you put into this AUA Update Series. I know our listeners will benefit tremendously from the full lesson.
Thank you so much. Thanks again for having me. I really enjoyed the discussion, and I hope this lesson serves as a good practical resource for any urologist who's caring for these patients.
And to our listeners, thank you for joining us for another episode of the AUA University podcast. For the complete lesson 2 on perioperative management of urinary diversion, along with the full AUA Update Series and other educational resources, please visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we'll see you on the next episode of AUA University Podcast.